Hello, everyone, and welcome to another audio podcast in this series around the SZ Loci Equinox. This is another audio podcast around and in this series wherein wherein there'll be a sort of an overview around something that's known as or abbreviated as FSGS or focal segmental glomerulosclerosis. This is an RPSG and KDOS collaborative aligned to a storm Ballistix production as part of a this is part of the Ballistix addition and as part of this, I will the basis will be where there will be an overview around sort of these aspects. So sort of an intro into FSGS classification, FSGS from sort of from FSGS from a sort of a primary or primitive pathophysiological basis. There'll be a sort of a perspective around adaptive FSGS, a genetic basis around FSGS, virus associated FSGS, medication associating FSGS, FSGS signs and symptoms and diagnoses, some of the sort of therapeutic approaches that have been sort of documented and evidenced, some aspects around urinary tract infections aligned to FSGS and something referred to as acute pyelonephritis in context of scarring, and also sort of scarring VUR or vesico-ureteral reflux, and some sort of a basis around risk factors for renal scarring or scarring in context of FSGS, as sort of more specifically, and there will be sort of a sort of a pediatrics basis for this for this and in this sort of audio podcast as well, and the audio podcast here will sort of provide will have a sort of overall summary around FSGS towards the end as well. So to begin with, FSGS or focal segmental glomerulosclerosis generally refers to as scarring or hardening of nephrons or glomeruli. And FSGS is sort of a type of glomerular disease and relates scarring or sclerosis across renal pathophysiology. And what I mean by sort of across pathophysiology, generally where there are the functional components around the sort of around renal anatomy. Generally, though, the scarring is consistent with where blood enters through renal tubules and exits from renal tubules, and it is those parts those parts around the sort of the nephrons and glomeruli that are primarily affected in FSGS. And the scarring of FSGS sort of only once it takes place between in and around afferent, for example, afferent and efferent arterioles. For example, the scarring also takes place in small sections or small parts within the glomerulus, and it is the most is perhaps one of the most difficult or challenging a challenging sort of a challenging and enigmatic enigmatic sort of sort of basis around or in at least in relating to in relating to sort of a nephrology sort of disease. It can occur as a primary disorder without an identifiable cause, or as an illness secondary to a variety of primary based concerns. It is also one of the most important causes of acquired it's in context of FSGS classification. So there's a primary form, and a secondary form from a sort of primitive basis. The primary form can actually can be sort of identified as idiopathic, or sort of from an unknown cause. And from the secondary form, there is a virus. There can be a virus associated form that links to that, and it can also be a medication induced form, and perhaps more sort of troublesome, is the genetic basis of FSGS. So primary FSGS is where the mechanism surrounding podocytes. So podocytes again are linked with nephrons and glomeruli. Podocytes are involved in sort of a protective mechanism in and around sort of the glomeruli. So the mechanism of podocyte injury can involves a circulating factor, a cytokine that makes particular recipients or suspect or high risk sort of recipients more susceptible to FSGS. The most common form it is FSGS again is unfortunately quite common or can be quite common in adolescence in adolescence and sort of young adults, and commonly associated with again nephrotic syndrome or nephrotic range the sort of nephrotics as well as where the disease or FSGS is linked with sort of protein leaking or proteinuria, reduced plasma albumin levels, and also other sort of predisposition aspect sort of bases as well. Histologically, FSGS may manifest as what's referred as a tip variant, collapsing variant, or on a basis of sort of where there is a NOS variant as well. Currently, current therapy ranges and can be based on immunosuppressive agents, including sort of glucocorticoids and calcineurin inhibitors, and therapy may in sort of specific cases sort of in context of adaptive FSGS. It arises after a period, a sort of a duration where the nephron level glomerular hyperfiltration and glomerular hypertension, and increased single sort of a nephron glomerular filtration rate are sort of at higher levels, and leading to progressive cycles of glomerular sort of hypertrophy and podocyte hypertrophy, and stress and depletion as well. Total GFR can be elevated and normal, or can be elevated, can be normal, but also can be decreased from as part of the diagnoses. Adaptive FSGS is also associated with an increased sort of total GFR, including wherein, for example, there can be congenital cyanatic heart disease involvement. There can be sickle cell anemia that sort of disguises the symptoms disguises the sort of FSGS. Alongside this, there can be androgen abuse, or in context of FSGS, as well, and sleep apnea, and high protein are also, again, are all, in line with an adaptive FSGS as well. The duration of single nephron glomerular hyperfiltration is measured, or is typically measured, and renal biopsy features sort of support a diagnosis of adaptive FSGS. It can include sort of large glomeruli findings. And the clinical features include a normal serum albumin, which is unusual, unusual in primary FSGS. In context of the genetics, the genetic basis, the number of genes associated with FSGS rises or increases every year. Some genes are associated with a syndrome that includes external manifestations, and this can include this can include and provide a sort of a basis that recipients might have a mutation in a particular gene. And some genes are associated with characteristic changes in basement membrane morphology, or mitochondrial morphology. Every sort of family with a child diagnosed with FSGS should be offered a sort of a genetic sort of investigation, as part of the diagnoses. Therapy, sort of genetics, and context of therapy. So therapy for genetic FSGS is generally conservative, and on the basis of renin aldosterone system antagonism, and calcineurin inhibitors can have an effect in sort of a selected recipients with sort of a genetic basis around FSGS. Coenzyme coenzyme Q10 can or has some advantages for individuals with mutations in certain or where there's evidence around certain mitochondrial defects as well. In relating to sort of a virus associated FSGS, so HIV type 1 is strongly has been strongly associated with FSGS. Other viruses that have been associated with FSGS include cytomegalovirus or CMV, parvovirus, B19, and Epstein-Barr virus or EBV. And certain parasites have also been associated with FSGS, presumably by stimulating innate immune pathways. And these can include, for example, Plasmodium falciparum, and also known as a form of malaria, Schistosoma manasoni, and filariasis. And the mechanisms likely involve direct infection in and around sort of the podocyte components of the renal around the renal sort of pathophysiology and sort of anatomy, sort of specifically. So in context on medicine associated FSGS, interferon or IFN therapy has been associated with the development of collapsing collapse or collapsing glomerulopathy, and bisphosphonates have been identified and documented as being associated with podocyte injury in FSGS. Lithium therapy has been associated with medicine associated FSGS in some works that have been published, and which typically can be reversed within weeks after, for example, stopping particular medicines that, for example, have a lithium component, if and where it may be warranted or required. Sirolimus again is primarily an immunosuppressive regimen, also referred to, or has been referred to, as Rapamune, and generally has been associated with increasing high plasma levels in FSGS recipients, and so in FSGS recipients, other particular calcineurin inhibitors and corticosteroids or glucocorticoids are sort of the main forms of treatment to sort of offset the use of, for example, sirolimus being used, and anthracycline medicines, including doxorubicin and duodomycin, have been associated also with FSGS as well. In context of signs and symptoms around FSGS, generally the list is pretty generic. So early stages, for example, may not cause any symptoms. There may be swelling in parts of the legs, ankles, and around the eyes. There can be extracellular fluid again in line to swelling. There can be extracellular fluid apart from sort of the legs and ankles and around the eyes. There can be extracellular fluid elsewhere in and around pathophysiology. There can be a foamy sort of appearance in urine, and the foamy urine is a result, for example, of high protein levels in urine, referred to as proteinuria. There can be low levels of protein in the blood as well, and also signs and symptoms that on their own are generally vague, but with other symptomologies can actually help, provide a sort of can help clinicians and even pathology teams and laboratory in context of laboratory medicine provide a good basis around FSGS, and those can include, for example, fatigue, poor appetite, headache, headaches or headache in particular regions around the head, itchy skin, or itchy skin, or for example urticaria, and there can be shortness of breath, and also sort of nausea as well. In context of sort of FSGS diagnosis, so it is based on the detection of segmental sclerosis and hyalinization around sort of the glomerular tuft, where investigators and clinical teams really are able to provide recipients who are suspect or high risk a sort of more formal diagnoses. So, for example, here, in context of sort of clinical history, laboratory findings, and sort of biopsy findings, there are sort of a checklist, if you like, of FSGS diagnoses based instructions, so that clinicians with recipients who might be suspect or high risk can use and have been where the literature provides a sort of a more updated bases around these particular sort of themes, if you like. In relating to sort of the histological findings, this here in this sort of slide or view, basically there's the sort of histological sort of snapshots, if you like, of sort of the glomerular lesion. And then there's the defining features and associations, and the clinical features that are linked to the form of glomerular lesion. And where alongside the glomerular lesion, on the left-hand column on here, there is a sort of a basis around a histological subtype. So, for example, you have NOS, you have perihellar, cellular, TIP or TIP, and collapse, and these are the histological subtypes that from a sort of pathology basis that can be used or are used in around to provide sort of histological bases around diagnoses for the types of FSGS. So in context of sort of therapeutic approaches, so I mentioned a few in one of the earlier slides, but generally therapy should be individualized on the basis of the particular form of FSGS, as well as the factors particular to the recipients. FSGS may be responsive to therapy with glucocorticoids, for example, although relapses are unfortunately typical as well. Medication-associated FSGS can be managed by stopping the offending medication, and virus-associated FSGS can be treated by initiating particular antiviral therapy, at least in sort of published sort of data. Antiviral therapy in some cases can be helpful in FSGS related or relatable sort of conditions, and treatments for FSGS sort of specifically again can be corticosteroids, immunosuppressive drugs where applicable, plasmapheresis. So plasmapheresis is more of an invasive sort of approach in context of therapeutics. In literature and sort of published works, there is evidence to suggest that plasmapheresis is and can help. And so, however, plasmapheresis is not for example not common in comparison to for example corticosteroids and immunosuppressive drugs, ACE inhibitors, and angiotensin receptor blockers or ARBs, diuretics can and have been used or are used in FSGS recipients. So in context of urinary tract infections and acute pyelonephritis or APN, and as a general theme in where UTI and APN are relate to scarring. So acute pyelonephritis or APN in pediatrics or children can lead to renal scarring and acute renal parenchymal damage and subsequent permanent damage as well around the sort of around the urinary tract. Extensive scarring can progress to renal injury with subsequent hypertension, decreased renal function or renal insufficiency, and proteinuria, and of course end stage renal disease or ESRD. Permanent renal scarring has been observed or identified in cases or recipients where urinary tract infection has been evident in 15% to 60% of pediatrics or children or young people who are affected as well. Acute inflammatory response eradicates the invading sort of bacteria where UTI is evident and is responsible for early renal parenchymal damage and subsequent scarring. In context of VUR or vesico-urethral reflux and scarring, the rate of scar formation is significantly higher in infants or young people with a basis around VUR than in those without. The incidence of renal scar formation was significantly or has been significantly sort of higher where there is formation, where with scar formation, there is evidence of reflux or VUR, where clinicians and sort of pathology teams are able to grade the sort of correlation in that context. In literature also, VOR has been identified as severe in cases where there is also an association with risk of permanent renal damage. As sort of a side aspect is VUR on its own. VUR on its own. VUR on its own. If can only cause problems or damage if for example if it's number one, if it's for example associated with a primary diagnosis around renal, where there's a renal basis, but also where, for example, VUR, if there's subsequent episodes around VUR, in context of the urinary tract being affected, then that can cause permanent damage to the renal tract, renal tubules and urinary tract. VUR increases the risk of sort of scar formation, especially so in context of the sort of risk factors that pertain to the scarring, there are several bases. So first and foremost, there's vesicoureteral reflux, as per mentioned, VUR. There's bacterial virulence. There's host defense factors. There's genetic susceptibility. There's acute pyelonephritis. There's hydronephrosis. And again, there's urinary tract infections or UTIs. In context of pediatrics, those with an increased where there's increased levels of procalcitonin are potentially more susceptible to conditions that can and do relate to, for example, FSGS. And children or young people can have a higher sensitivity in identifying with severe reflux, and those with a high fever who are younger than 6 months of age as well, and where there's again a recurrent urinary tract infections, where there's clinical signs such as poor urinary stream or palpable renal pathophysiology, infection with atypical organisms, and where there's evidence of bacteremia and or septicemia as well. So in summary, along with FSGS, renal scarring is often or renal scarring has a basis around where there can be a sort of an alteration to the renal physiology or renal pathophysiology, particularly where there can be sort of evidence of hypodysplasia and can be associated with urinary tract abnormalities such as obstruction of high-grade VUR. FSGS is generally a chronic condition aligned with a scarred glomeruli, which unfortunately are not able to sort of rejuvenate or repair, and treatment can slow can slow the progression around renal disease. Every recipient responds different to the forms of treatment. Some recipients with FSGS unfortunately gradually get worse until renal failure or renal disease is pronounced. And some patients or recipients respond well to treatment and may live or can live with FSGS for many years whilst being monitored for any sort of any sort of main signs that can induce sort of more severe sort of changes around renal anatomy and pathophysiology. And so I want to say a few acknowledgements, or at least highlight a few acknowledgements here in the co-development of this overview, where there was an academic collaboration, academic basis, alongside two organizations, the Renal Patient Support Group (RPSG) and the Kidney Disease and Renal Support Group for CADARS for Kids. And once again, this was another Storm Robotics production, and I hope it's been I hope this has been a helpful sort of overview around FSGS. Thank you.